We're going to call up now the next panel for research to practice to improve health in building policies. Joel Kimmons is the moderator.
Good morning. This is all interesting. We sort of worked out this panel so we could work ourselves out of the moderator role. We organized the panel so that we have we looked at the sort of history of great oration, and we said, who stands out? And for those of us with kids, we thought, well, it's clearly the Muppets. And who are our favorite people in the Muppets? It's those grumpy old men. We thought about who can we find some grumpy old men, and what can they do? So we're going to have two grumpy old men, although they're not that old. Liz says she still can't hear. Really? Okay, well, these mics are not that sensitive. That's a note to everyone. Quick summary is grumpy old men from the Muppets drove our thinking as great historical oration in our society, and we're going to have a couple of them moderating three excellent speakers. You can hear three presentations, and then Q&A back and forth. Please, while the presentations are going on, think about questions. Kelly and I will be picking up questions in the audience from you. Please write them on a sticky or something, hand them to us. We will deliver them to the moderators. Kelly is now going to give a quick introduction to the moderators, and the moderators themselves will actually introduce the panelists. So we have multiple tiers here. We can probably kill a little bit of time. People come back in from the restroom.
Sure. Hi. So my name's Kelly Warden. I lead health research efforts at the U.S. Green Building Council, which includes a longstanding partnership with the University of Virginia School of Medicine. My colleagues, Dr. Matt Trowbridge and Chris Pike from USGBC, are going to be speaking later throughout the session. But as Joel said, we were very thankful to the overall conference organizers for tolerating our desire to mess things up a little bit. So we blended what was initially going to be a separate policy and practice track. We actually chose to combine them, the idea being that we are trying to break down the silos between policy and practice, and really bring those two fields together. So if are we ready to bring... Okay, yes. So as Joel said, I'll go ahead and introduce our two moderators. As you've seen in the program, we've got extensive bios on everybody. So I'll just quickly introduce. We have Kevin Kampschroer, who's Chief Sustainability Officer and Director for the Office of Federal High Performance at the General Services Administration. And in this role, he is tasked with creating tools, platforms, trainings to help the GSA improve the performance of their diverse and aging portfolio of commercial buildings. We also have Dr. Casey Chosewood, who's Director of the Office for Total Worker Health at the National Institute of Occupational Safety and Health. And in this role, he is responsible for working to promote the health and well-being of workers across the world. He's also Assistant Professor at Emory University School of Medicine. And as we mentioned, the moderators will go ahead and introduce the individual panelists.
Well, hello, folks. It's great to be here. Really looking forward to a great discussion about health, the built environment, especially looking at it really through the lens of policy, which we think is a very powerful lever to move some of these opportunities forward. It's also my pleasure to be joined by the other speakers here today. We have a great group of people that I think you're going to enjoy hearing from. And I'm happy to co-moderate this panel with Kevin from the General Services Administration. Kevin, it's good to be with you today.
Likewise. I'm glad for you coming in.
Yeah.
This distance.
Thank you. So I understand you're going to introduce our guests today, and we'll get started.
Yes, and there's got so much that they want to say and that you want to learn that I refer you to the introductory materials in the book, and this constitutes my introduction. I also realized as I was taking the metro in here that last month I missed the 50th anniversary of my being in the building business. Wow. And it made me think about the session today, because when I started, we were actually putting toxins in the buildings, and I contributed to that by installing asbestos in homes, which I then later at GSA systematically took out of buildings. And it's sort of this this trajectory of we didn't really know what we were doing to let's find out about the toxins, let's get the toxins out, then let's not put the toxins in. And today, the most exciting thing about today is that we're not talking about toxins, we're talking about how we can create and maintain buildings that improve the health of the people who use them, remembering that the only purpose for a building is for the people to use it in the way it was designed or in the way they decide that it should have been designed. So with that, I'm going to turn it over to Esther Sternberg for the first talk. We'll go do talks and then we'll have questions.
Thank you very much. So I'm Esther Sternberg. As you heard from Michael Gottesman earlier, I was here at NIH in the intramural research program as a senior scientist and section chief for 26 years before I was recruited to the University of Arizona at Tucson to create a research program for the Center for Integrative Medicine and to create an institute on place, well-being, and performance, linking the Center for Integrative Medicine, the College of Medicine, the College of Architecture, Landscape Architecture, Planning and Landscape Architecture, and now the College of Engineering and the College of Agriculture. So we have a very broad interdisciplinary program, which I will talk to you about, but it all started, let's make sure this, no. It all started with Kevin Kampschroer when I was here at NIH, and he was Director of Research for the GSA. And now, as you see in the program, he's Director of High Performance Federal Green Buildings and Chief Sustainability Officer for the GSA. So it's been an incredibly productive collaboration where we are basically taking data from research to design, and now ultimately you'll hear into policy and standards. And really that's how we're going to change the landscape of health and well-being for all through design. The project that we've been working on since I came to the University of Arizona is called Well Built for Well-Being. There are many team members here. You're going to hear this afternoon from Dr. Casey Lindberg, Brian Gilligan, Kelly Canada, and others. And I'm going to speak about just some aspects of what we've been doing in this Well Built for Well-Being project. As I said, it started back in the year 2000 when Kevin Kampschroer came to me at NIH as a sister agency and said, how can we measure the impact of the built environment on human health, well-being, and performance? Because we want to optimize the health, performance, and productivity of the people in our 2.4 million square feet, billion lots of square feet that the GSA builds and manages. And so we began this project where Julian Thayer, who was then at the National Institute on Aging, worked with us, and we used objective measures, heart rate variability and activity measures, to look at the impact of the built environment on various aspects of stress and the relaxation response and other aspects of health. And we took a federal building in Denver, where the old space, as you can see on my right, your left, had significant mechanical noise. There was poor ventilation, little daylight. It was being retrofitted, and we measured the office workers in those spaces, and we found that in the new space, the office workers in the new space where there was reduced mechanical noise, improved ventilation, daylight, and views, had significantly lower neuronal stress response measured by heart rate variability, and significantly lower hormonal stress response measured by salivary cortisol. So that was really objective evidence that changing the built environment for the good can significantly impact and lower the stress response of the occupants in it. Interestingly, those occupants were not aware subjectively of any change in their stress response, and I'm going to emphasize this in our current study. So the question then became, how do you go from inputs, that is all these different features of office building design that you all as designers can impact, how do you go from space planning, light, sound, indoor air quality, and removing toxins, of course, that's really important. How do you go from that to optimizing performance, reducing absenteeism, improving productivity, all the things that owners and builders want to see. So we measure the outputs that we can measure scientifically. That is things like cognition, sleep quality, stress response, physical activity, and so on. There is a very important relationship between performance and the stress response. It's called the YatesDodson Curve. There's an inverted U-shaped curve between the activity of your stress response and your performance. So if you imagine a rainbow upside down on the stage, if I were very relaxed, half asleep, if I were in a spa, I'd be over there, I'd be lying on the floor reading a book and relaxed, and the organizers would be stressed. So I need to get my stress response up to peak in order to perform at peak. That's what gives me the focused attention, the vigilance, and the ability to perform at peak. The problem occurs if the stress response falls over the edge of that curve, and that's when you fail, that's when you freeze, that's when you can no longer function. During the day, especially the work day, but anybody's day, you are exposed to many, many different kinds of stressors. And when you add all these cumulative stressors together, we call that allostatic load. So if you can imagine that you wake up in the morning with an empty sack on your back, and every little stressor that you experience, you put into that sack. By the end of the day, you are carrying this heavy, heavy sack of stress with you wherever you go. And that is what causes the problems on the body. And it is known that chronic stress is associated with decreased vaccine take rate, increased severity and frequency of viral infections, prolonged wound healing, prolonged speeding of chromosomal aging, and speeding of cancer growth. So this is not good. It is not good for people to be in a stressful environment. And to the extent that the building design can reduce that stress, you, the designers, we who work with you, have the ability to impact people's health throughout the day. Now, how can you all impact that? Well, you can intervene at any one of these places in this reciprocal relationship. So the stress and relaxation response is related to physical activity, and I'll show you some of that data in a minute. Also to sleep quality. So to the extent that building design can influence and impact and reduce the stress of any of these pieces, you can improve health. And that goes also for the scale that we heard earlier about in the urban scale, reducing the stress of any environment in inner cities and at whatever scale you're talking about. So this is how Well Built for Wellbeing worked. We worked with our industry partners, Acclima, you heard about them in the earlier session, who have developed these wall nodes and wearable nodes to measure 11 different attributes of the built environment in real time. And they do the data analytics to do this: light, sound, temperature, humidity, volatile organic compounds, various aspects of air quality. We worked with Bijan Najafi and his team when they were at the University of Arizona, now at Baylor, to measure heart rate variability, which is the way we measure the stress response in real time. And Casey Lindberg will talk about the work that he did as part of our team with the University of Arizona's Department of Psychology, Matthias Mell, to pull all this together and to measure in real time, people's subjective responses in terms of mood, stress, and so on as they were sent questions through the smartphone. This study involves massive data analytics to merge different data streams collected with different granularity to tease apart relationships that are important for health. So just to tell you what heart rate variability is, heart rate is the speed of the heart. Heart rate variability is the variability between the beats. In the interest of time, I'm not going to go into this in detail, but just so you can remember, high heart rate variability is a good thing. It is healthy. Low heart rate variability is a bad thing. It is stressful. What is the worst heart rate variability pattern that you can imagine? A straight line That's how you remember. It's not good to have low heart rate variability. So I'll talk about two different aspects of our studies. There are many studies coming out of this, and Casey Lindberg will talk more in the afternoon about this. So we looked at office type, the workstation design, and how does that impact these human health outputs that we measured. Well, it turns out comparing bench seating to cubicles and private office settings, that people in bench seating had significantly higher activity levels and lower stress response levels compared to people in cubicles and private offices. Now, you building designers who work with people who are shifting into a different kind of office design, most of the time from private and cubicles to open seating, may know more about the complaints that people have about being in this open office design. When we did single surveys, that is retroactive surveys asking people subjectively how focused they felt on their work, whether they were in private, cubicle, or bench design, the people who were in the bench seating and the cubicles reported that they felt less focused on their work based on this single kind of subjective measure. However, in real time, there was no difference. This is a really important thing to remember, and it's something that we will highlight in our discussion because it's important to do real-time objective measurements of these different outputs in order to really understand how the place and space affects your health. So, sedentary activity was lower in private offices and in cubicles compared to compared to bench seating. I think I'm going in the wrong direction here. What about carbon dioxide? Carbon dioxide is very important. It has impacts on cognition. So carbon dioxide in our study varied with different types of rooms and with occupancy. The more people in the room, the higher the carbon dioxide. You're breathing out carbon dioxide. Why is this important? Because levels of carbon dioxide that impair cognition and are associated with fatigue are actually fairly low. So as you can see in the open office setting, there was levels of carbon dioxide were all within a range that had no impact on cognition or fatigue. In the conference room, at times, and related to the numbers of people in those conference rooms, the levels were associated with levels of carbon dioxide that are associated with lower cognitive performance. And in the phone room, which was very small, the levels of carbon dioxide could actually go up so high that the cognition levels are known at those levels to be within 50% reduction. And the levels of carbon dioxide varied over time and on different days in different rooms related to the numbers of people in the rooms. Well, the obvious solution to this is improve the HVAC in all of these rooms so that you're breathing fresh air. But we can't do that unless you measure what is happening in those rooms. So what can you do about these reciprocal relationships? There are many things we can do about the reciprocal relationships, and we're going to discuss that in the discussion period. So I'm going to turn it over to the next speaker.
It's you.
Oh, do you want this?
Oh, yeah. Well, good morning, and thank you for including me in this panel. It's a privilege to be back at NIH. I was here in the 1980s as an epidemiologist at National Heart, Lung, and Blood Institute, and subsequently at CDC. Make sure this is...
It's counterintuitive.
Oh, it's the
arrow that's the opposite way.
Okay.
Yeah.
All right, good. I'm Andy Dannenberg. I'm on the faculty at the University of Washington School of Public Health, working in both environmental health. I'm coming from a public health background, but also with an appointment in the College of Built Environments in the Department of Urban Design and Planning. I also work with the architects in the school. Oh, you're right. It's what I'll be talking about is links between research and policy, and what you're hearing about through a lot of today's and tomorrow's presentations are examples of healthy building research that is already well underway. Some things we know a lot about, some things we need to know more about. And it's a whole range of issues on physical activity in stairs, nature contact, you heard some this morning on chemical exposures, radon, lung cancer, a whole range of issues for which we have a lot of research. But how do we turn that into policies that can actually do something and improve the public's health? I want to focus on looking at the higher level of some of the societal problems that have health impacts and have ways where design matters in addressing these impacts. And so I'll go through each of the ones here, ranging from obesity and housing and aging and urbanization and energy and water, the whole range of issues for which there are major societal issues, health impacts, and where design matters. So starting at the beginning, looking at obesity, all these are things you're probably well aware of at some level. This is a picture that's widely circulated. But design can influence what choices people make. And obviously, if you put stairways and escalators next to each other versus put the escalator and elevator more difficult to find, you will influence what choice people make. Here are examples of just how do you build a stairway that people want to use, and there's some nice stairways out in the lobby here that probably many of you use because they're in front of you, and the elevator is not as obvious. The example here on my right is a door on the second floor of a building in Canberra, Australia, where the signs do everything they can to keep you from going down those stairs. You know, keep it closed. There's something in fine print about violation of the Fire Brigade Act and do not obstruct and do not open. You're on the second floor of a building. We had come out of a health promotion meeting, and of course I opened the door and walked down and no alarms went off. But you know, a door like that is clearly going to influence your choice. Maybe I really shouldn't go through it. Housing is an area with major health impacts on asthma, respiratory disease, injuries, lung cancer, radon, a whole range of issues. And again, design can make a difference on how do we design buildings so they're healthy and affordable, particularly considering equity issues, as you heard in the earlier speaker this morning. We know a lot of the features of what needs to go into a home to keep it a lower risk place. And some of that is the chemicals and building materials, but there's a whole range of issues on ventilation, on insulation, on air circulation, a whole range of issues that all have to do with how we design buildings to promote health and get healthier homes. Another societal issue is an aging population. We're all getting a bit older, and a range of things as we have reduced vision and hearing and mobility. We can design the built environment around us to reduce the adverse effects of what the building can do to particularly make it better accommodate people with disabilities. So for example, one policy approach is put in requirements so that here's a bathroom with grab rails in it. So things that we can do a design that makes it a healthier place for people with those disabilities. Another one is looking at mental health. I think someone showed this picture earlier of where a whole range of issues that can approach mental health, but daylighting. We have good evidence that a place that is daylit is going to help the mental health of the people working in it. And so there are ways we can incentivize daylighting as part of design, and I think that gradually is catching on as people decide that's where they want to be. Another, the general issue of urbanization. We have a large part of the world's population is gradually becoming more urbanized and fewer people in rural areas. And various ways to incentivize the design, the urban design. This is more the community level, but it includes what goes on in buildings, so that a place is walkable and is a more pleasant place to be. Another one that Richard Louv used the term nature deficit disorder, that we have good evidence that green space and nature contact are very good for health, for physical activity, for mental health, for social capital. And again, it's an area that we can at least incentivize. We're probably not going to require that every building have lots of green space within it and next to it, but we can incentivize it, and I think the market will support it, that buildings have more contact with nature in and around buildings. The pictures there from Seoul, Korea, where they daylit one of their highways they took down and revealed a stream, and it's a very heavily used place within Seoul that did not have that much green space until they did that. Chemical exposures, you heard a good bit about this morning. They have a variety of health impacts. And we can set policies, and you heard the red list mentioned. That's the bullet centers, that is the picture there, about choosing what materials you're going to use. And I think you heard a good bit about that, and probably will hear more. Energy issues, a lot of it has to do with how we design buildings. And energy relates to health in that people who are having to pay for their energy are less likely to have the resources they need for other necessities of life. There's a, do we heat or do we eat type of approach. And good design can give us more energy efficient buildings and location efficient buildings. And LEED actually works very much in this direction, as you well know, is focused on energy efficiency. There are cities around the country and states around the country that are either encouraging or requiring LEED certification. Unfortunately, there's a few that are discouraging it, and for varying reasons, several of the southern states and Maine have rules that actually discourage the use of LEED. But much of the country is focused on how do you get more energy efficient buildings. Water, another issue, again, comes into design. Water relates to hygiene and to habitability and to food supply. When there's too much, we get floods and the issues that go there. We can set policies for design that affect how water is used, how it's handled for both shortage and excess. And LEED has done very well as water is part of that. And natural disasters cover a lot of these areas, can cause injury and death and displacement. And again, we can set policies that look at resilience and look at how do we handle things that are foreseeable, particularly on such as flooding. And some of that can be insurance, so that if you have a place that is flooded multiple times, the insurance companies really do not have to keep being willing to rebuild. And at some point when the insurance rates are set high enough, then a place that should never have been built doesn't need to be rebuilt. Climate change covers many of these areas. Again, many health impacts well known in the climate change field. And again, we can incentivize designs that do address various climate change issues. A lot of working with architects has, when you say architecture and health, the word comes out, well, you mean healthcare architecture. And certainly a lot of work has been done for healthy buildings in relation to hospitals and clinics and healthcare architecture. But the concept of design and health and architecture and health goes well beyond just healthcare architecture. It really applies to all buildings. A lot of healthcare architecture is based on evidence-based design, and that really becomes central. How do we choose what is the right thing to do? And there's a good bit of literature on everything from lighting and carpeting and how to lay out the nursing floor and all these issues that relate to how do we get better healthcare architecture. But we need the broader issues, and New York City has done work on active design guidelines that really look into some of the issues on the broader scale, not just limiting it to healthcare architecture. Several other ways of getting healthier design fall under codes, and this is both building codes and zoning codes. And these are policies, and these can be set at various levels. Building codes set the requirements for what's going to be in the building and the quality of initial construction. A lot of focus on issues such as disability, access, egress, air quality, safety, resilience, sustainability. Building codes accompanied by, in various forms, fire codes, plumbing codes, electrical codes, energy codes. All of these can be set in a way that they are promoting health. Housing codes are separate from building codes generally and focus more on the post-occupancy issues such as pest control or habitability. One of the higher level policy approaches is to have public health more involved in setting these building codes and in setting housing codes. So it's sort of a missed opportunity that a lot of these codes are set without as much direct public health involvement as they could have. Zoning codes on a higher level, on the community scale. And zoning codes are interesting in that they can either be very helpful in helping get that walkable community with a lot of good features and smart growth for those who have heard of it, mixed-use development, accessory dwelling units, having the pedestrian bicycle infrastructure. All those can be very positive for a healthy community from zoning codes. But in other places, zoning codes actually serve as barriers. Of zoning code that puts a minimum parking rather than a maximum parking is actually adverse to the health of that community. And so as zoning codes get upgraded and public health professionals can be involved in that, we can get healthier zoning codes. Another area, again, it has been mentioned, I'm sure you'll hear more about it, is the various healthy building certification standards are basically policies that can be encouraged or used to get healthier buildings. And several types that you've heard about, and we'll hear more about FitWell and Well, Living Building Challenge, and others. The FitWell, which I think you'll be hearing more about, was developed in part with GSA and CDC and others. And you'll see the three that I'm going to mention all, and it's currently administered by the Center for Active Design, that all of them pick which categories of health, and there is substantial overlap among the different categories. So that's FitWell. Here's Well, it takes a more holistic approach to what buildings should look like, and again, the categories that they chose to look at. And then the Living Building Challenge, again, with its categories and substantial overlap among all of these. All of these certification standards, as they can influence policy as the market and be compatible with the market, as the market is asking, can we get healthier buildings? Having these certification standards does help drive to get healthier buildings. I've been working some with the American Institute of Architects that has put health as one of their important categories to work with. Liz York, who's here, and I are co-chair of the Design and Health Leadership Group at AIA, and have been working on a number of these issues. In relation to that, we have an American Institute of Architects and American College of Schools of Architecture Design and Health Research Consortium, which is a group of, I think, we're up to 19 pairs of universities around the country that are pairs working with an architecture school and a school of public health or equivalent, and looking at how do we advance research in design and health issues. AIA also has a building research information knowledge base known as BRIC that gathers a lot of this information as a source for it. We do have a book that I worked on with Howard Frumpkin and Richard Jackson, looking at more on the community level of how do you get healthy communities, but also with individual chapters looking at how do you design healthy homes and workplaces and healthcare settings and schools. Just some of the next steps forward. Evidence-based design, as mentioned, has been more on the healthcare architecture field. There's certainly a lot more room to get more evidence-based design in the broader field of design and health. Cost-benefit matters. It was mentioned this morning that we need to do things that make sense from the cost point of view, but a lot of healthier choices with the right materials and designs don't necessarily need to cost anymore, and certainly if you can take the longer view, have a lot of benefits. As mentioned, trying to get more public health input into building and zoning codes can get us build better codes that can make a difference in the long term. One area I work in as an academic is how do we teach people in the design profession and in the public health profession that their fields overlap and influence each other. And so there's a number of courses around the country that are health and built environment where we get planning students and architecture students in the same classroom with public health students, and they're learning each other's language and they're hearing how the fields interlap. And then further use of healthy building standards, I think, will help lead to those standards to healthier buildings. So our long-term goal is, can we make health-promoting design every bit as routine and desirable as green and energy-efficient design? Right now, you really can't imagine a client coming to an architect and say, build me an energy-inefficient building. That just wouldn't be. Of course, you expect energy efficiency to be part of modern design. Well, why shouldn't health promotion be also part of modern design? Thank you. That key, not that one.
Great, thank you. Thank you, Andy. Good morning. Good morning. It's been a long day. Wonderful to be here. Joanna Frank, I'm the CEO of the Center for Active Design. So we are a nonprofit organization, so a little bit different from most people in the room, and we really sit at the nexus between the research community and all of those who are making decisions about our built environment. So that could be on the private side, the developers, the designers, it could be on the public side, policymakers, elected officials, community members. So we sit in between the two, and our job is to translate. And we've been talking about that a lot today, but it is a crucial role because we don't speak the same language, we don't have the same priorities, but all of us have a common interest in health. So that is our role, and that is what we've been doing ever since we were born out of the Bloomberg administration 5 years ago. So I guess in this crowd we are the new kids on the block, although 5 years feels like a relatively long time. So this is when I usually start. When I'm talking to those in the building industry, we really have to start by talking about, what are the health issues that are facing society, our population at different levels. And so I think it's really important to understand that this is not common knowledge. It isn't something that those making decisions about our built environment really consider as in their purview. Why should I care about this? Why has this got something to do with what I do? So it's really important that we start by actually making the case for health, and this is something that we all need to be addressing with urgency. This is not something that can wait. This is something that we really need to be prioritizing now. So, the more extreme statistics, the better. To be able to talk about children is always, I think, persuasive. Even when we're talking to financial institutions, it's hard to not actually care about life expectancy of our children. So it's really important to start there, really setting the issue that health is a goal that we should all be really addressing in an urgent manner, and that we all have a role to play. And I think it's very important to understand that outside of this room, this maybe is, kind of surprising to you guys, but most people actually don't think of health as their priority. Like, we have to, as people who are interested in imbuing health into design and development practice, we have to understand and educate ourselves about what are the existing priorities of cities, elected officials, real estate developers, financial institutions, and we have to understand how we can demonstrate that by prioritizing health, you are also addressing their existing priorities. I can't go into a financial institution and persuade them that health is the thing that they should be concentrating on. It's never going to happen. However, we can make an argument that is supported by the evidence base that by prioritizing health, it is also good for their bottom line. And so that is the dance that we are engaged in. So one of the things you have to do to start with is you have to set a standard. You have to actually define, what do we mean by a health-promoting environment? We really have to ensure that this is implementable and practical, and that it really speaks to a wide audience. So no jargon, no assumptions. Let's really talk about what is possible, what is practical, and what will have the greatest impact. So don't just tell me everything I could do. Tell me what will be the most impactful. So a real estate developer will say, just tell me the 10 things that I need to prioritize. And if you could you tell me in the order I should prioritize them? So it's very important that we cut to the chase and really talk about what is going to have the greatest impact on the greatest number of people. How should I get started? What should I prioritize? So at the Center for Active Design, we still believe in old-fashioned publications. So the Active Design Guidelines were published by New York City in 2010, and it was kind of a landmark moment of translating health research into practical design strategies for the design community. This publication was designed very much for designers. I think it was very influential. It is obviously cited many times. Building Healthy Places, the next publication, we worked with the Urban Land Institute to create a toolkit for the real estate development community, specifically what is within the purview of the decision-making for real estate developers, and what about that can they actually influence as far as health outcomes. We set a very clear delineation. These are evidence-based strategies. We are looking at longitudinal research studies. We are looking at many different research studies, a body of evidence. This is an entirely new conversation for most in the building industry. I was educated as an architect quite a long time ago, admittedly. We didn't talk about health. We didn't talk about research. I had no understanding of the difference between a cross-sectional and a longitudinal research study. We simply don't speak that language. So it's really important that we set up the basic building blocks so that we, as an industry, as the building industry, are educated and can actually differentiate between what is strong, what is a powerful body of evidence, as opposed to what is something that's emerging or a best practice. So with these publications and the the certification program we're going to talk about, FitWell, it's really setting a standard. It's really doing that work for the industry. It's really saying, okay, we're going to do a massive literature review, we're going to translate this into strategies, and then we're going to present it out in a way that it will appeal directly to those who are making the decisions about the built environment. And Assembly, which is the newest publication that we just put out, was actually published 2 weeks ago. So very exciting. We've been working on it for 4 years. And it was really looking at what is the role in the design of our community and the maintenance of our community and impacts on levels of trust, both trust in neighbors, but also trust in institutions, participation in public life. So what is it about where I live that encourages me to participate and encourages me to actually interact with my neighbors? Or what is it that actually starts to deteriorate that trust? Also, stewardship of the public realm. What is it about where I live that actually supports my idea that I have ownership over my space? And then lastly, agency. So these are all really important, and they build onto that body of knowledge. So we're very excited. I have a few copies of Assembly, and you can download it also. So when we're talking about health promotion, and we're talking about how do we take those policies and actually ensure that the people who are making the decisions around policies are aware that they actually are impacting health. I mean, every day decisions are made about infrastructure spending in cities, about HR policies, about capital investment in real estate portfolios. And every day those decisions are made without consideration for the health impact that is actually happening, because it's happening whether or not someone knows about it. So how do we disrupt that decision making? How do we get into that conversation so at least those decisions are being made in a way that it's informed? One of the ways is to just directly appeal to the return on investment argument, and I think it's actually the most successful way. So you really need to show those who are making decisions that there is a return on investment that directly relates to their priorities. So if I'm if I'm an employer, if I have a business, what is my number one fiduciary responsibility? It is to have the greatest possible return for my investors, for my company. So what are some of the kind of big issues that businesses face? Retention and attraction of staff is one of the number one issues that businesses are facing, especially as the market contracts. So we have, less and less unemployment, so we're really competing for talent. Businesses are really aware of the fact that there is a competition for talent. They are aware of the cost of having to retain staff and replace staff. So it's important for us to know the stats on the fact that there is massive demand from individuals when they are looking at where they're going to work, that the condition and the design of their built environment and their office spaces is actually one of the most important key things that they're thinking about when they're deciding where to work, including it's on a par with other benefits, so financial benefits. So this is what this stat is showing. And this is very persuasive to a business. If they're like, oh, I'm having issues retaining my staff, and if I look at the way that my office is built and maintained and operated, and I can actually start to address one of these big issues, then this is something that I feel like is for me. This is something I am now going to pay attention to. Another very much real estate related stat, but also very important, that when I am building at a neighborhood scale, building a walkable community, it's what we're all talking about, but why? Why would I build a walkable community if I'm a city, if I'm a neighborhood, if I'm a real estate developer? And I think, again, like being able to make the argument that there is massive demand out there for walkable communities, for communities that promote health. And so there is an opportunity. So whether I'm a community or a city, and I want to attract people to my city, or if I'm a real estate developer and I want to attract people to my development, there's an opportunity right now. I really need to address the walkability. I need to address the proximity to amenities, all of the stuff that Andy was talking about, in order to do my job, which is, in the case of a real estate developer, to have the fastest possible lease-up rates, the greatest possible sales, etc. It's okay that there's a financial reward for building healthy places. It actually obviously makes my life a lot easier, but it actually is the thing, I think, that will bring about the market transformation that we need. So again, we've talked about it a little bit, and I talk about it a lot, the return on investment argument, and that's why I'm here talking about it. So the more data we have, that really talks about, what are the benefits to the different people who are making decisions. The more data and the body of evidence that we can actually produce around this, is the more traction that this movement is going to get. So I need to be able to show everybody in that decision making why it's good for them. So if I'm an investor in real estate, I need to understand, why should I care about whether the building is promoting the health of its occupants or that the community, if it's a bond, is actually healthier. If I'm a real estate developer, I care about lease-up rates, I care about my pro forma, I care about the sale of my building. We need this data, and we don't have it right now. We have a few examples, we have case studies, and we have an emerging body of evidence, but we don't have the data that we need at this point that I would consider a proper evidence base. So now to kind of change gears a little bit. So we can make the return on investment argument. We know it's important. It isn't there yet, but it's moving in the right direction, and obviously that's where many of you come in. So the setting the standard piece that is also so important is where FitWell comes in. So you've heard this morning a lot of the buildings that you've seen, a lot of the discussion has been around this building has WELL certification, is LEED certified, and FitWell is the newest of the certification programs, and it was created by the CDC and the General Service Administration. So it was created by the federal government. It was then launched and the Center for Active Design was selected as the operator of FitWell, and it's really that kind of how do we bring all of this knowledge together and translate it into a standard that then can really be scalable? How do we ensure that this knowledge is actually getting into the hands of everybody who's making a decision around our built environment? Really important that we create the tools that ensure that this isn't just a small conversation. We want to embrace everybody and ensure they have access to all this amazing knowledge. So it's actually key that the CDC and GSA was part of the kind of the beginning of FitWell as far as its kind of popularity and its credibility. So really important that we have this public-private this relationship, as was mentioned earlier. So we, the Center for Active Design, we're just a small nonprofit. We're good at being in the middle, but we need everybody to be doing what they are experts at, and we will translate. Andy already showed this diagram. So FitWell is looking at a holistic impact on health. We're looking at community health, as well as equity, as well as physical activity, food access, the reduction of morbidity, a big one, and absenteeism. So feelings of well-being is the mental health piece, and then safety, something that's very important, obviously, within a building. And every strategy within FitWell has a body of evidence that links it to at least one of these health outcomes, and many of them actually impact multiple outcomes, as everyone, I think, in this room is aware. And those strategies actually allow the building to actually get more points per strategy. So every strategy is weighted, and the amount of points that you get for the strategy is directly a reflection of the strength of the body of evidence and the measurable impact on health. So really being able to set those priorities. So not just these are all the things you can do, but this is actually where you should start. Let's give everyone a roadmap about how to optimize their environments. And it's also looking not just at holistic health, but kind of all aspects of the built environment. So not just the building, but what about the actual amenities and context that that building sits within? So if a building is sitting in a neighborhood that has access to parks, has well-maintained sidewalks, has access to transit, you are going to have higher levels of physical activity because of the way that you're commuting to work. If you're in a location that you have to drive to, like this. Actually, no, you can take the subway. If you're in a location where you have to drive, there isn't that opportunity for physical activity. So location is key, looking at walk score, looking at access to transit. It's also an equity issue also. Access is looking at accessibility for all, so really kind of an equity issue. Looking at all aspects of the building, so not just the building and the inside of the building, but actually its siting, its location, the outdoor space, the cafeterias, the food access, etc. It's also looking, FitWell was designed for the GSA's portfolio, so it's very much optimized for a portfolio approach. And again, this is that issue of equity. It is essential that we don't just look at one or two buildings, but that we look at buildings across entire portfolios. And therefore, we ensure that this is actually going to be something that everybody benefits from. So This system itself is a very high-tech interface portal that we've developed that really allows for optimization across massive portfolios of buildings as well as individual buildings. It's also looking at existing buildings. 90% of the buildings that we have exist today. So how do we take those buildings and then support them in making incremental changes to both the physical design but also the operation of those buildings? How do we embrace the facility managers as well as the designers, as well as the occupants and owners of those buildings? How do we bring all of those people into the party and also give them the credit that they deserve for their piece of the puzzle that they provide us? So we're looking at commercial interiors, you're looking at single-tenant buildings, multi-tenant buildings, and also we just expanded into multifamily residential. So not just the workplace, but also where you live as well. And then the FitWell interface itself is actually driving data. So this is the interface, as a snapshot of the interface, and it actually provides information to the users about how they are impacting health. It's all cited. You can click on buttons and see citations. Each one tells you which of the health categories you're actually impacting. And this is an educational tool. Like me in my building industry, I have no idea that being in a walkable community actually impacts my mental health. That's something that I just learned today. So that's exciting and interesting. And so really providing that knowledge to those who are using the interface is really important. And then also rewarding them, giving them the data, making it a little gamified so that they can compete with each other within a portfolio, within an organization. So very important. The user face is also super user-friendly. Like let's just eliminate barriers to entry and to access. This doesn't have to be super complicated. This is something that's why it's important we translate. I don't want someone not benefiting from this information because they don't understand, kind of the criteria, or they don't understand how they're supposed to actually achieve this particular strategy. So we can do that with technology. It's obviously very powerful. We can also deal at really massive scale. And then this has been discussed a lot, and that's the equity issue. We have partnered with Fannie Mae, that large financial institution that I'm sure you're familiar with. And what we've done with Fannie is to create a new loan program that means that if you are the developer of affordable housing, where 60% of the units are at 60% or area medium income or below, and the property is FitWell certified, you actually get a reduction in your loan of 15 basis points, and they reimburse the cost of the certification system. Because we know that eventually we will be able to make a return on investment argument for the market rate properties, but we don't think we can make a return on investment argument to the developers of affordable housing for their return on investment. So it was essential that we put a little bit of weight on those scales and ensured that there is a return on investment argument for the affordable housing developers to ensure that there is equity of access to health promoting housing for all. Otherwise, the affordable housing market would just be continuing as it is now, and that's obviously, that's not really addressing where we could have the greatest possible impact. So it's partnerships with people like Fannie Mae that really start to help to address this balance and make this knowledge just kind of part of the market. We want it to be ubiquitous. We don't want it to be unusual. Yes?
You're over.
Yes, sure, sorry. Okay, I'm sorry. So let me just click. We've got lots of people using it. And it's very exciting because we've seen that there was a real demand for this. So in just a year and a bit, almost 500,000 people are already being impacted by FitWell. So thank you.
Thanks very much. We do want to have some time for questions and discussion. So if you have a question, we'll let you start making your way to the microphone. And I'll just lead us off by saying thank you all very much for really great information that you shared today. And Joanna, perhaps I'll start with you. There is a lot of talk about lack of socialization in our communities. The more digitally connected we are, oftentimes the more disconnected we are. Can you talk a little bit about the policy and built environment opportunities to bring people together, to increase socialization, connectedness, both at work, community, where we live, work, play, worship?
Sure, absolutely. So with the work we just did with Assembly, we're actually now seeing there's a body of evidence that shows that designing spaces that really invite people to participate is essential in starting to address that social isolation issue. We can do that through signage, so multilingual signage. We can do that through creating spaces in all our neighborhoods that really actually are resonating with the community. It's also about the process on how we design them. So we really look at a design process that actually encourages community participation in that design process. So it isn't for us to say, oh, this plaza worked in this community, I'm going to do exactly the same thing over in another community, but actually engaging with the community and looking at the unique community context and how you reflect that in the design and aesthetic of the spaces. So it's really actually drawing from the community what they prioritize and what resonates with them, rather than assuming that we know what will work. So I think it's not just the design solution, but it's the process by which you get to that design.
Great, thanks very much. Kevin's going to have some questions as well, but I have one for Esther before we move to Kevin. Loved all the talk about stress. We know it's a major occupational hazard. Stress is the centerpiece of the obesity epidemic, cardiovascular disease, hypertension, so many challenges related to stress. If you could suggest only 3 policies that you think would be most influential at decreasing the stress associated with these environments, where would you put the money?
Well, in the study that I described, which was done in 4 federal buildings with 232 office workers, and actually one of the federal buildings was actually here at NIH, we did find that increased activity during the workday was associated with lower stress levels, and that carried over to the after-work hours. So if there's a single thing that one can do, it's increase your activity. Right. Increasing your activity can be enhanced, as we've now heard, by various aspects of building design, the active guidelines, and various other ways to improve activity, which office layout was one of them.
Great, thank you. Kevin?
Sure. Andrew, you've done a lot of health impact assessments, and yet you talked a lot about things you thought were ready to go. How do you decide when you know enough to move from the research realm to the let's just get it done realm?
Yeah, good question. I guess the short answer is you go with the best available information, knowing that your information is never going to be perfect. And I think we have enough information on what makes a pleasant environment. Some of that can just be, feedback from occupants as what makes a good environment, that use that to guide where you're going. So it's don't let the perfect be the enemy of the good type of thing, where you have reasonable information to go with it.
So I have a question for each of you in turn. How will we know that we've been successful?
Well, how will we know that we've been successful? We, in our studies, have used objective measures. And it's not that subjective measures are not useful. They're very useful. They need to be done in a holistic way, as I described in our findings, in real time, and not just a subjective question-answer post-occupancy questionnaire, which turns out to be not as reliable as how people feel in real time, in real place. And combining all that with the physiological measures that we have, the psychological measures that we have, even the sleep quality measures that I didn't talk about. So I think we need to have objective measures. We're in an age of exploding real-time sensor movement with lots of data that can be crunched in real time and that can give the vision would be ultimately to have a dashboard in real time and tell you where your health status, your stress status, your relaxation status, your performance status is in real time compared to the built environment, and then ultimately to change the built environment in real time to optimize your own personal space, because that's the other thing. This is very individualized, and we need to do this on an individual basis because everybody has a different optimum.
Great.
I think there is a role for post-occupancy evaluation beyond what has been done, and some of it, as you're saying, really can be done with sensors. Why shouldn't we have sensors on stairways and elevators to get a sense of who's using them? And if you put up some signs or give some incentives and people use them more, well, why should that data be fairly available, since sensors really are something we really have good technology in? So I just think there's a bigger role for post-occupancy evaluation than has been typically done.
Great.
I think for us, it will be when we see health infiltrate underwriting for financial institutions, when we see it in every RFP that's issued, when we really see it being part of the fabric of the decision-making process around what gets built, what gets funded. So that's what we would consider success, to go all the way up to the top of those who are actually controlling our built environment, like from the financial and policy levels.
So I have one last and a somewhat sneaky question for my fellow moderator.
Great.
So you've done a tremendous amount of work with basic safety.
Right.
When you are dealing in a situation where the most important thing is just to make an unsafe place safe, how do you incorporate the idea of getting well-being and health into that thinking when all you really have to focus on is safety?
Thanks so much for the opportunity to respond to that, because so many people these days are trading their health each and every day for wages, right? They go to work, they experience 8, 10, 12 hours of really tough working conditions, and they go home at the end of the day with less health than when they arrived. So a high-quality employer pays attention to all of the opportunities, from the built environment, the policy environment, the supervisory opportunities, to the opportunities to create social space, interaction. All of these things have tremendous opportunity to not only immediately impact the safety of the people in the space, but also add to their health so that they go home at the end of the day with more health than when they arrived that morning. So a great example would be when you're designing an environment where you know workers are going to have additional load, additional stress, is not only build in, amenities for great food, physical activity, opportunities for good screenings, awareness about what makes health possible, but also think about the actual job itself. How is the job crafted to not take away health? How can we build in the ceilings of healthcare facilities lift devices so someone doesn't have to do that manually? How can we create safer spaces where actual manufacturing gets done? How can we pay attention to lighting, to sound, to the implementation of break spaces and places where people can, interact and encourage and relate to each other? So I think there's a number of ways that we can improve safety as another important lever to better health.
Thank you.
Sure.
So your job when you're asking a question is to ask a question, not to give a speech.
Brief.
Please, brief question so that we can get the panelists time to answer.
Emphasis on brief, I understand that. So my name is Dr. Stephanie Taylor. I'm a physician, and I'm thrilled to see 3 other docs up there. I came into this building through a different way, which was through looking at patient outcomes in hospitals. And as a physician and as someone who does a lot of research, I'm very data-driven, and I am frustrated by the physicians being over here and building people being over here, although I'm talking to the wrong crowd when I say that. But we have a ton of health data. And what is your experience, like Esther and Andy and all of you, in actually bringing in, how can we bring in some of the data that we have on white blood cell counts and electrolytes and, not just subjective questions. I mean, subjective questionnaires are awesome. I'm not saying they're not, but what's your experience in bringing together more hardcore medical data?
Great. Thanks for that. And Esther or Andy, you want to start off?
Just quick. LEAD now has a credit for involving health people in a design committee for a new building. And recently that we have a new building going up on the University of Washington campus that there is a design committee, and I'm the health person sitting at that committee. Needless to say, a complicated building has many, many inputs, so just because it's coming from the health world doesn't mean it's going to happen, but at least it's a step in the right direction to get health considered in the design phase.
So
This is amazing.
There's no question that all different kinds of data are going to be very important in proving these concepts. And the type of building, when Kevin first came to me in the early 2000s to ask me to measure the impact on health, well-being, and performance of the built environment, he wanted me to measure not only the stress response and heart rate variability, but also the immune response. That's my background. And I said, great, we can draw blood. And he said, no, these are office workers. So I said, well, how am I going to do it? He said, that's your job, figure it out. It's your fault. So Kevin got me started on this whole program, which is a very important piece of what we're doing at the University of Arizona, measuring biomarkers in sweat. Immune, stress biomarkers, neural, cognitive, whatever you want. And we can measure pretty much everything in sweat that you can measure in blood. And that is a program now that is really a huge program, mostly with the Air Force Research Labs, other parts of DoD. Ultimately, the idea is to develop a smart shirt where we will be able to measure every aspect of health, not just the physiological stress response, but all biomarkers, and get at that question that you're asking. Right now, we don't have the capacity to do that in real time. There's a whole industry called the flexible hybrid electronics industry working towards developing these kinds of biosensors that will detect continuously and in real time biomarkers in sweat. That's maybe 10 years away to have anything like that we can apply. So right now, the only way to do that is in controlled settings where we do, and in fact, across the road, we're actually doing this now at the Walter Reed National Military Medical Center, where we are working with Patty Doyster and Marnie Silverman and a group at the center at USUS to measure the impact of what we call the Green Road, which is a part of the Rock Creek Park that was retrofitted that goes through this military base, to measure the impact of this green space on wounded warriors who walk through that space as compared to walking through the urban, noisy, unpleasant environment where trucks are going by on the military base. And so we're going to be measuring biomarkers in sweat as well as heart rate variability and so on. But you have to tailor the kinds of measures to the kind of environment that you are looking at. And right now, the kinds of questions that you've just asked, what is your blood cell count, what is your, what are the blood levels of various biomarkers, can only be done in a hospital environment. And that's the kind of thing that Roger Ulrich did and published in 1984 in his famous study comparing people who had hospital beds looking out over a grove of trees versus a brick wall. So, right now, what you're asking can be done and is being done in hospital environments. We hope that in the not-too-distant future, we'll be able to take that out of the hospital environment and apply it to any environment using these kinds of wearable devices that will measure all those biomarkers in sweat.
Great.
Thank you.
Thank you so much.
Thank you. Okay, we'll take another question from the audience. Remember, a 2-sentence question, and I'm going to ask our panelists also to edit responses to just a few sentences each.
Okay, mine's just a comment, so maybe it'll be shorter. I just have a personal experience that I think is really interesting. I am an architect, a sustainability consultant, and I'm getting my MPH right now. And 99% of the people that I told about my career path said, oh, a complete change in a career. And this was in the design industry, it was in public health, and the fact that there is not that connection on either side or the general public, that built environment and public health need to be integrated, I think is one of the biggest challenges. And it seems like that is one of the things that needs to be concentrated on across the board for general public knowledge, but so they ask when they're designing a building, when they're occupying a building. But also, I was really surprised to see on the public health side also that it wasn't an association with public health in buildings. So I thought that was interesting.
Thank you. Andy?
There's about a half a dozen, at least, concurrent degree programs in public health and urban planning. I'm not aware of any in public health and architecture.
Yeah, so actually one of the things that we're doing at the University of Arizona Institute on Place, Wellbeing, and Performance is we have developed a master's in architecture for health in the built environment. So there's a long history of an association between urban planners and public health epidemiologists. That goes back, 30, 40 years? So at the urban planning scale, this is a long history. At the individual building scale, it's not. So that's one of our goals at the Institute on Place, Wellbeing, and Performance at the University of Arizona. And anybody who wants to take, here's a plug, anybody who wants to get a master's in that area, please come and see me, see Casey Lindberg afterwards, and we're happy to enroll you immediately.
Great. We have time for the other side of the room.
Yep.
Okay. My name's Lita Lewis, and I'm an interior designer, though I have my degrees in architecture. And I have been practicing in sustainability for a while, but focusing on well-being specifically for the past number of years. I really liked bringing up Dr. Dannenberg bringing up the connection to building codes. And I'm wondering, because I saw LEED go from marginal to mainstream, in part when they saw standards as being aspirational, but then also looked at codes to look at raising the floor of our performance of our buildings. So where are we seeing opportunities to push forward, whether on local levels with mayors or nationally, to integrate a lot more of this, which has a direct connection to health, safety, and welfare on which codes are built? Where are we seeing movement on that in the codes?
So I'm going to take a quick crack at that one first. I think the adoption of ASHRAE 189.1 by the International Code Council is a large step forward. The current revisions of 189 are incorporating a tremendous amount of these new things that we've learned about health and buildings into that as code. The more that gets at the national level, the more likely it is to be adopted at the local level. It's worth noting that in this country there are still 29 states that don't have a basic energy code. So there's a tremendous opportunity for local work as well, and all politics is local, as you know. So I think that the code is hugely important. The national code bodies, I think, are headed in absolutely the right direction, listening very carefully, and the work that needs to be done is on the local level, mostly on the state level.
So I just want to add that one of the reasons it's been so exciting to work with Kevin Kampschroer and the GSA team is that this, in my mind, is one of the fastest ways to get our research findings into practice. And that's exactly what Kevin is doing now, and working with various standard-setting organizations to do. And it's also important because GSA manages and builds 2.4% of all buildings in the United States. That's a very large footprint. And as we heard earlier, that's one way, if you have a large footprint, to instantiate these findings into actual practice, because if you demand that the buildings be built to optimize health and you don't pay somebody to do it unless they're building them in that way, that's going to change practice also. And we heard from Harvard and others who are doing that.
Great. Maybe time for one final question.
Concerning heart rate variability and measuring, which I think is really brilliant. Do you know of any sensors that don't use wireless? Because I'm seeing some research that wireless can affect heart rate variability itself, and I don't want the sensor to impact the reading.
Well, first of all, you point to your wrist. So there are many heart rate variability sensors out there, more and more each day, and that is the basic way that all of your, I won't name brand names, but your trackers actually measure your activity and your stress response. We use a different kind of measure. It's a chest-worn device. It is wireless, and we validated it against its gold standard against laboratory quality. It's not the kind of thing that you can go out and buy on your own, but for the purposes of the research and to get the outcome measures that we're looking at, we had to use research quality heart rate variability monitors. Yeah.
Thanks. Great. Thanks for that. Just perhaps one final 30 seconds each. Anything you'd like to say, Joanna, to wrap us up?
I mean, I think it's great that this discussion has become more and more common. You know, I feel like 5 years ago we were trying to convince people that there was a connection between health and the built environment. We are no longer having that conversation. So I think that there has been a tremendous kind of movement forward. So let's just keep going.
Great. Andy, final 30 seconds.
I've been working in built environment for a while, and I've seen sort of three different areas between the architects, the urban planners, and the transportation worlds. And I wish they're all built environment. They all have health impacts. And I guess I would like to see more interactions among them. I go to separate national meetings in each of those fields and talk to different people in each of them. I'm amazed that they aren't more integrated and talking to each other more.
Thank you. Esther?
Well, I think it's wonderful that this conference is taking place at the National Institutes of Health and at the main amphitheater in Natcher here. You know, in my 26 years when I was an intramural scientist here, it was not something that was at the priority of NIH. And it's really very exciting that this is happening here, that we had the blessing of Michael Gottesman, the deputy director of NIH. And I would say that, yes, maybe 5 years ago it wasn't something that people in the health world were thinking about, but it certainly is now. So.
Great. Kevin, any final thoughts?
In my remaining 6 seconds to get done on time. Yes, organizations care about performance, and what we have been proving and have proved is that health improves performance, that improves the business, that improves the bottom line. So any business that doesn't invest in the health of their employees is an idiot.
Couldn't agree more. Thank you guys very much. Wonderful panel.